Yes. So good afternoon, everybody. Thank you for joining. My name is Sanja Hermans, and I work at the Institute for Medical Genetics at the University Tübingen in Germany. And I'm the training manager of the European Reference Network for Rare Neurological Diseases. We have today, I will share my screen to give you just a short information on our webinar. We will have a 30 to 35 minutes presentation, and afterwards we will have approximately 15 minutes of questions and answers session. So please, if you have any question, you can write it in the Q&A section, which is in the lower toolbar just on the left side. And so today, and also for all our webinars, the target audience are neurologists, residents, pediatric neurologists, geneticists, and other paramedical personnel involved in patient care. We are recording this webinar, so we will put the recorded version on our website at the latest 2 weeks after today, along with the slides. And also you can check this other website for useful information on the different disease groups that we cover in our network. So when the webinar ends, your browser will open a satisfaction survey. So it would be great if you can fill it in, and because we get a valuable feedback on how the webinars are performing and can continuously improve them. So please take 2 to 3 minutes to fill that survey. You are all muted, but I hope you can hear me all well. This is for the acoustic experience to be better. And I would like now to introduce our speaker today, Nicole. I have to admit that this is a short summary of her person, which is for us a very committed and engaged member, and working very enthusiastically in our network. So I'm really honored to have her today to present this webinar. Her current position is consultant child neurologist and associate professor, and she's affiliated to the Amsterdam Leukodystrophy Center, the Emma's Children's Hospital, and the Amsterdam University Medical Center. She has received her training in pediatrics and child neurology in Heidelberg in Germany and in Zurich in Switzerland. Her research focus is on leukodystrophies, metachromatic leukodystrophy, Krabbe disease, and hypomyelinating leukodystrophies. So, Nicole, thank you again. Thank you very much for accepting this invitation. I'm really honored, and as I said, really happy to have you here. Also, seen your engagement in our network. So, I can stop my screen sharing and you can go ahead.
Thank you all. Welcome to the webinar, Introduction to Leukodystrophies. Thank you very much, Sanja, for introducing me and also for teaching me how to use that system. For being so patient and organizing everything around it. So I hope you can all hear me, and we will start. So first I would like to know about your background. What discipline you are working?
Okay, so I will start the poll. And you can just choose the right answer. Okay. So 15 seconds left. So here are the results.
Oh, so we have a lot of adult neurologists. I hope you will also enjoy the lecture because the main background today is on pediatrics. Although I won't focus too much on special leukodystrophies, perhaps that's something for another webinar. So I think we can continue.
Mm-hmm.
I hope that by the end of this webinar, you know the current definition of a leukodystrophy, to understand the basic principles of MRI pattern recognition, to propose a diagnostic plan for a patient with a leukodystrophy, recognize the most important treatable leukodystrophies, and know about important aspects regarding patient care, not only curative treatment, but also patient care. So to get us all going, what do you think is a leukodystrophy? That's a multiple choice question again. Please see what you would like to answer.
Okay, I will start the poll.
And only one possibility is correct.
Okay. 30 seconds left. I think there are some people that cannot vote. I would suggest that you make a screenshot of what you receive as a failure message and send it to me by email even afterwards, but because we will try to solve this. But now we have 33 out of 42 attendees that have voted, so I will show the results. Okay.
So that's a very good result. A genetic disorder primarily affecting white matter is the correct answer. And as I will show you, not all leukodystrophies are progressive. And not all leukodystrophies start in childhood. So let's continue. That's the current definition of a leukodystrophy. And I think it's important to remember that all white matter components may be affected, not only myelin, but also the blood vessels, microglia, astrocytes, oligodendrocytes, which are producing myelin, of course, but also the axons. All components of white matter, and all can be affected in a leukodystrophy. And also important to remember that all modes of inheritance are possible. Autosomal dominant, de novo, autosomal recessive. A lot of leukodystrophies are autosomal recessive. You all know X-linked leukodystrophies like X-linked adrenoleukodystrophy or Pelizaeus-Merzbacher disease. So that's also a possible inheritance mode. And mitochondrial leukodystrophies like Kearns-Sayre syndrome. And the age of onset can really be even before birth in the most severe forms to late adulthood. So that's all possible. And of course, the spectrum of leukodystrophies in adults is different from the spectrum and the causes in children. Also, the clinical manifestations in adults are often different to the ones in children. The most recent classification of leukodystrophies dates from 2017 and was thought out by Mario van der Knaap, the head of our center, and Mariana Bujani, our neuropathologist. I will actually provide the exact citations at the end of the webinar, so you don't need to write that down or look it up now. One category are myelin disorders, hypomyelination like Pelizaeus-Merzbacher disease, demyelination, which would be X-linked adrenal leukodystrophy as an important example, myelin vacuolization as another example of myelin leukodystrophies. Then you can have astrocytopathies, and you might know Alexander's disease, which is a representative of that group, leukoaxonopathies, where the axons are primarily affected, leading to myelin involvement secondary to that axonal involvement. You can have microgliopathies and also leukodystrophies, which are caused by small vessel disease, inherited small vessel disease. So these are possible categories of leukodystrophies. And you also see that they reflect actually the different white matter components which may be primarily affected in a leukodystrophy. The symptoms of signs in a leukodystrophy patient frequent are spasticity, ataxia, nystagmus, especially in the hypomyelinating disorders, extrapyramidal movement disorders, dysphagia, mild intellectual disability. Patients can also be severely intellectually disabled, but as a rule, motor impairment is more severe than cognitive impairment in patients with leukodystrophies. The other way around in patients with Rare matter diseases, where you have more pronounced cognitive impairment compared to less pronounced motor impairment, certainly at the beginning of the disease. In patients with late onset, and I mean with late onset, late adolescence and adulthood, you have another group of symptoms predominating the clinical picture, which is often a slowly progressive dementia and also psychiatric symptoms. And these may even occur without other neurological signs and symptoms. Important to remember that in patients presenting with a new onset of psychiatric symptoms, it's of course very difficult to think of leukodystrophy as a possible cause of the disease. So often in that patient group with the psychiatric presentation, the disease is diagnosed quite late in the course. There are also symptoms and signs beyond the brain, you should remember. There are some frequent extraneurological symptoms and signs, dental involvement, hypodontia, ocular involvement, cataract, retinopathy, for example. Skeletal involvement, I have an example of a patient with the bone dysplasia here with broad hands and abnormal bone X-ray, endocrine involvement, skin involvement, hearing loss. These are all possible extraneurological signs, and these help you to differentiate among the leukodystrophies, because some clues are quite specific for leukodystrophy. Look at that patient with the hypodontia, missing his incisors, and that's typical for 4H leukodystrophy, and the 4H stand for hypodontia, hypomyelination, and hypogonadotropic hypogonadism. So these can be a good diagnostic clue leading to more targeted genetic testing, for example. I already mentioned that leukodystrophies are not necessarily always progressive. Progressive improvement can be seen in several leukodystrophies. For example, mitochondrial leukodystrophy,
Nicole, we cannot hear you very well.
Normal signal of cerebral cortex, and the had completely stabilized, actually learned to work.
Nicole, do you
Yeah.
hear me? Yeah.
Yes.
It was really saccadating, and then it
Okay. We start
stopped
again.
with the yeah.
Okay. That's okay again?
Yes, I hope
Good.
so. So yeah, on this slide you were not. We couldn't hear you.
Okay, I'm sorry. So we try again. That's a patient with a complex 1 disease, a mitochondrial disorder, and you see here his MRI at the age of 2 years with the clear signal abnormalities in the supratentorial white matter, and also these surprisingly, the patient was clinically very stable, and you see that at the age of 12 years, the white matter abnormalities have greatly improved. And mitochondrial leukodystrophies can improve over time. They also can deteriorate depending on the diagnosis. There is a mild leukodystrophy with the macrocephaly, megalencephalographic leukodystrophy with subcortical cysts, and the dominant form also shows resolution of white matter abnormalities over time. And then there's a recently described transient hypomyelination with mutations in that gene, which improves. So not all leukodystrophies are progressive. Important to remember. The MRI is the diagnostic tool for leukodystrophy. Maya van der Knaap has actually developed this pattern recognition, and this is really very helpful for a diagnosis. But you have MRI may be normal in a presymptomatic patient. It may improve or even normalize, and it also may be non-characteristic, certainly in adult patients. With and also in disorders having progressed a long way, signal abnormalities may become less specific. So just to show you some examples of how powerful the pattern recognition is, you see here 3 children with and you see that these 3 MRIs look completely different. I show you the noses. That's a patient with Alexander disease, and you see here the gradient with the frontal predominance of the white matter abnormalities compared to a much better signal in the occipital white matter. You see the involvement of the caudate nucleus and the putamen and the normal thalamus. And in that patient, we see a global involvement, very homogeneous of the entire white matter, no gradient at all, a normal caudate nucleus and a normal putamen, but an abnormal pallidum and a clearly involved thalamus. And in that child with the MLC, you see that the white matter is also diffusely abnormal and swollen. You see that swollen aspect, and you also see that basal ganglia are completely unaffected. And these clues help you to diagnose many leukodystrophies with their MRI appearance, and that's what we call pattern recognition. So the first question you have for an MRI scan, is it a leukodystrophy? And of course, you have a differential diagnosis if a patient has white matter abnormalities on his MRI. You can have other genetic disorders, gray matter disorders, for example, but you also can have acquired disorders. Periventricular leukomalacia in babies or children who were born prematurely is a classical acquired disease involving brain white matter, but also intoxications, deficiencies, infections, inflammation, and neoplasms can actually look a bit like a leukodystrophy. So we go to the next multiple choice question, and I think many of you will know the answers. One might be genetic, other acquired, both genetic. So please have a look at the images and make your decision.
Okay. So I hope your window, you can move your window so that you can still see the
Oh, yes.
pictures.
Yeah,
No,
okay.
no, I
Oh,
have
sorry.
done that, and I hope that everybody can do it also for himself or herself, and then. Okay, 10 seconds left. I'm sorry for those that cannot participate in the live voting. It seems that they have some problems, but I will forward them to Zoom and check what is wrong, and hopefully we will resolve this problem until the next webinar. I will now show the results.
That's very good. I think you have already seen quite some MRIs of patients with the leukodystrophies. That's true. Perhaps, Sonia, you could close the,
Yes,
or I can
yes,
also close.
yes. Okay.
That's genetic. It's an X-linked adrenoleukodystrophy, and that's really pathognomonic MRI appearance with posteriorly dominant signal abnormalities involving the thalamus, the projection fibers, and also with the contrast enhancement, the different zones of white matter involvement. So that's a classical X-linked adrenoleukodystrophy, a genetic disorder. And that's also a disorder you all know. It's multiple sclerosis with these multifocal, overly shaped lesions, not completely symmetric, although occurring on both sides, and actually perpendicular to the corpus callosum. So it can be quite obvious, but it can also be more difficult. So again, two examples and the same question.
Okay, now the same question and other pictures, other scans. Okay, 15 seconds left. Okay, so I will show the results now.
Yeah, thank you. I agree, it's really tough. And I think that many of you voted for both are genetic because of the symmetry of the lesions. I try to continue. This is actually acquired. It's a child with after rotavirus encephalitis. Because you didn't have that information, otherwise you probably would have known the answer. But you see that the disorders can also look quite symmetric, but it's not very regular, the white matter involvement here, and very multifocal and inhomogeneous. In that patient, the supratentorial white matter abnormalities don't look genetic. That could also be mistaken for multiple sclerosis. But I think a very good clue for a genetic disease, which you never see in an acquired disease, is the symmetric involvement here of the inferior cerebellar peduncus and of the pyramidal tracts in this patient who has LBSL or leukoencephalopathy with brainstem and spinal cord involvement and elevated lactate. So the differentiation between inherited or acquired disorders. So how to analyze MRI images? We recently published a new paradigm for the MRI interpretations, and I take you through some of the aspects of this paradigm. And I think you see that you look at the prominence of the white matter abnormalities. Are they prominent or faint? In that case, it's most likely neuronal. Is it very non-selective white and gray matter involvement? And then it's most likely acquired. And multifocal, it's also most likely acquired. Of course, there are exceptions, but if that's not the case, it's most likely genetic. And then you have to determine the type of white matter pathology and analyze affected structures in detail, predominant localizations of abnormalities, more occipital white matter, more frontal white matter, for example. And then after you got through that flowchart, you probably will be able to make an MRI-based leukodystrophy differential diagnosis, which is now very short and perhaps even contains only one diagnosis like X-linked adrenal leukodystrophy. So let's show some samples, and these are all from the paper. You will get the information at the end of the seminar, and you can also read through it again. These are patients with non-selective white and gray matter involvement. Look at the involvement also of the cortex, and these hazy borders of the white matter involvement in this child with the gliomatous diffuser. And also in ADAM, you can have a white matter involvement, which is multifocal, but also a gray matter involvement multifocally. And compare that with the very symmetric, very prominent X-linked adrenal leukodystrophy, which is of course a leukodystrophy. And here are examples for faint and mild white matter abnormalities, which are typical for neuronal diseases, like neuronal leukofucinosis. You see this faint hyperintensity paraventricularly located of the white matter. And that's typical for a gray matter disease. That's not a typical signal of a leukodystrophy. And also in that patient, you don't have a very high signal of the white matter. It looks here even a bit normal. In other places, it looks like the cortex, the typical cortical atrophy with a pronounced atrophy. So that's also a gray matter disorder, not white matter disorder. And then you have to determine the type of white matter pathology if you think it's a leukodystrophy. Is it hypomyelination or other types of pathology? Here you see another type of pathology, LTBL, with a prominent signal abnormalities in white matter, and compare that to the less white signal of the white matter in hypomyelinating disorders. So hypomyelination or not hypomyelination is an important determinator in different disorders. I already mentioned the distribution of white matter abnormalities. You also already saw some examples of distribution abnormalities, and here are again some examples. You see here in MLC the diffuse involvement of the white matter. In LBSL, the multifocal involvement, actually reminding you perhaps of MS. in another patient with the RS2 leukodystrophy, a relatively recently described disorder, you see that certain tracts are involved, and you have a frontal predominance of these abnormalities. In a late onset Krabbe disease or globoid cell leukodystrophy, you have this posterior pronounced white matter abnormalities. In MLD, in the juvenile cases, actually more or less a global involvement with subcortical sparing. And in that disease, L2 hydroxyglutaric aciduria, you have the subcortical predominance. And all these examples are also explained in that article. You can also look for special features like white matter rarefaction, where you get disappearance or vanishing of white matter in vanishing white matter, cysts in mitochondrial diseases, anterior temporal cysts, and calcifications in Aicardi-Gouttières syndrome, and in paroxysomal disorders. You have, for example, these cortical folding abnormalities, this polymicrogyria. So you see that the MRI provides you with many clues helping to make a differential diagnosis. And that's not something you know after this webinar. You really have to look at a lot of scans. I also had to learn it. Mayo van der Knaap is really excellent in that. So you have to see lots of MRIs to be able to do that, but you can really look systematically at an MRI. And I hope that these slides and also this article helps you to do that. And then when you have decided it is a leukodystrophy, then you also want to confirm that diagnosis. It's a very suggestive MRI pattern, like in metachromatic leukodystrophy or X-linked adrenal leukodystrophy. And then you can confirm that diagnosis with a targeted testing. And if that's positive, you are there. If you don't know the pattern, so you know, you think it's really genetic, perhaps you also have clues from the family history, but the pattern is not suggestive, then you might ask an expert, or you go to non-selective genetic testing, for example, a gene panel for leukodystrophies, or whole exome or whole genome sequencing. And some hospitals or groups don't do targeted testing any longer. They directly go to the unselected genetic testing to make the diagnosis. And I think both approaches are okay. You have to look for the best way in your center. For example, if you really need a fast diagnosis because of treatment implications, perhaps the targeted metabolic or genetic confirmation is faster than these non-selective genetic testings. If you don't have access to genetic testing, you can do metabolic screening. And I think the lysosomal enzymes, the very long-chain fatty acids are important parts of that metabolic screening. If you don't manage to make a diagnosis, you should refer the patient to a leukodystrophy expert center. If you have a diagnosis, of course, you have counseling possibilities, family testing, management, and therapeutic options, which are important for your patients. This is a flowchart. It might be a bit different from your approach in your center, but that's certainly quite systematic way to test and to diagnose leukodystrophies. And nowadays, I think about 80 to even 90% of patients with leukodystrophy can actually achieve a genetic diagnosis with the new genetic testing methods, whole exome sequencing or gene panels. So the rate of diagnosis is quite high. But is it relevant at all for patients with the leukodystrophy? So, or doesn't it matter whether you make a fast diagnosis? That's a new question for you. So you get some time to think about it. And here you have more possibilities for the right and answer.
Okay, 10 seconds left. Okay. So here are the results.
Yeah, I think you all got the important things. I think the only answer which is wrong is this one. It's not important as leukodystrophies are not treatable anyway. Well, that's not correct. We don't have many curative treatment options, but there are curative treatment options. And I think one of the really important things is that it might be essential for a pre-symptomatic sibling. So well done. Oops, okay. When you think of treatment of leukodystrophies, you have to think of disease-specific treatments. That is really treatment of the leukodystrophy like a cure. And the two examples actually are metachromatic leukodystrophy and X-linked adrenoleukodystrophy, where you have gene therapy already in clinical practice for both disorders with good results in pre-symptomatic or very early symptomatic patients. So that's really the development of the last 10 years, that we have gene therapy now to use in these diseases, although still only in a study setting, not registered, but that will probably change soon. And that we actually also know much better which patients will profit from that treatment and for which patients this treatment comes too late, because that's also a possibility to consider. And then you have treatment of disease-specific manifestations. And one potentially life-threatening complication is Addison disease in X-linked adrenoleukodystrophies. So you have to check all your patients with X with that complication. And there are other disease-specific manifestations, gallbladder involvement in metachromatic leukodystrophy, myopia, severe myopia in 4H leukodystrophy, hormone white matter, but also in 4H. And I can actually mention more. You can also read about these in the recent review articles on leukodystrophies. And then there is the general management of leukodystrophy patients. Spasticity can be severe and painful, so that has to be something to follow and also to consider treatment if available in your setting, like intrathecal baclofen administration for the spasticity, which is a very effective treatment for many of our patients. Things like scoliosis correction, and adequate intake and growth if necessary with a gastric tube. These are all things you probably all do in your patients. It's important to take care of your patients because also in patients you can't cure, you can make a change regarding comfort and growth. I always like to mention recent cases, and this is a case I saw during the last month. A 6-year-old boy with no antecedents in his medical history. In the last month, increasing motor difficulties, falls easily, cannot step down from his bike any longer without almost falling. And at school, he has some problems concentrating, although he's still doing quite well. And at neurological examination, he's a friendly boy, he cooperates well, has a mild ataxia, mild pyramidal syndrome, but no elevated muscle tendon reflexes. And his brain MRI looks very abnormal. You see this diffuse white matter involvement, sparing the subcortical fibers. Corpus callosum is involved, and also the projection fibers are already involved. At spectroscopy, actually you see a low NAA, elevated And this is all typical for metachromatic leukodystrophy. And what you see here, the dots, or in the sagittal plane, the stripes in leukodystrophy. And you also see here quite nicely the sparing of the subcortical fibers. Huh? So the diagnosis was confirmed by genetic testing and also by enzyme activity. I would like to ask you what you would consider next for that child. So that's another multiple choice question. I think that's the last one.
Yes, I will start that one. Yeah.
And there is one wrong question. Sorry, one wrong answer. So I would like you to highlight the wrong answer.
Nicole, I think that maybe the participants have already started to choose the right answers. So it's just
for me. Yeah.
Yeah, it's just important for them to know that there are multiple right answers in this question. So choose all the right possibilities. Okay, I will show you the results.
I think that's important to test brothers and sisters for metachromatic leukodystrophy. So that's really a good thing. It's also good to look at the gallbladder because it's abnormal in many metachromatic leukodystrophy patients with also clinical implications like abdominal pain. You also should do an IQ test because that's one of the important criteria to do or not to do any longer hematopoietic stem cell transplantation. And to refer him to a pediatric hematologist for bone marrow transplantation without an IQ test, I'm not sure that's a good idea. And in this case, actually, the boy was too advanced to actually do bone marrow transplantation any longer. So all things in his in the findings, for example, the very abnormal spectroscopy, the very severe MRI involvement, when you score that with the MLD loose score, points to the fact that they do transplantation, unfortunately. But his 4-year-old sister actually also had metachromatic leukodystrophy, and she had a normal neurological examination besides absent tendon reflexes at her arms, a very good total IQ, and when we made her MRI, you see already that she has some white matter abnormalities, very faint but definitely present in especially the frontal white matter, but also in the splenium, in the genu of the corpus callosum. This child actually, because she was so well regarding neurological examination and IQ, she is actually eligible for gene therapy. In gene therapy, you all probably know that the own hematopoietic stem cells are transduced with a lentiviral vector to insert the ASA gene. And after myeloablative chemotherapy, these modified hematopoietic stem cells are the bone marrow and secondarily the brain, where they produce very high levels of the lacking enzyme, arylosulfatase A. So that girl has been referred for gene therapy. So the key points I would like you to remember is that leukodystrophies are heterogeneous genetic disorders primarily affecting the brain white matter. Not all leukodystrophies are progressive. There are some with even normalization of MRI abnormalities. Brain MRI analysis very often will help you to make a diagnosis when you use the pattern recognition approach. Genetic diagnosis is possible nowadays in the large majority of cases, certainly if you use the advanced genetic testing. Treatment options are emerging and timely diagnosis is essentially, certainly for possibly affected SIPs. And also when no causal treatment is existing, active management of patients with leukodystrophy, like spasticity treatment, gallbladder removal, hormonal treatment is important because that really also makes a change for them. That's a list of suggested reading. Use the initial MRI pattern approach article, review on several aspects of leukodystrophies, the pathological classification system, a consensus statement on preventive and symptomatic care of patients with leukodystrophies, and also a really great progress of the gene therapy in metachromatic leukodystrophy, as I also showed you a patient with that disease. So thank you very much. You see that's is a big team effort, leukodystrophy. So this is our group in the Amsterdam Leukodystrophy Center with some affiliated colleagues. And thank you for your participation and the great work with the multiple choice questions.
Okay, thank you very much. And now if you have some questions, you can write them in the Q&A section. I don't see any at the moment, but you can go ahead. We have a couple of minutes left. Okay. It seems that there is somebody who raised her hand. Can we, so somebody is writing in the chat, please write your questions in the Q&A section, but I can read that question. Can we have slides of PR Wolf?
Well, you can have my slides. Yes, I will prepare a PDF with all the slides.
Okay. Yes. Oh, okay. It was meant you because I didn't understand what he meant by writing that like this. Okay. Yeah. Of course, the slides will be put on our internet site, and I showed you the link before. So just go on ERN-RND and training and education, and then you will see it's quite user friendly. Okay. And there is one question about eye involvement in leukodystrophy. Clues.
Clues? Oh, clues. In what leukodystrophies it can be a clue. For example, myopia in hypomyelination, hypodontia, and hypogonadotropic gonadism. These patients, majority has high myopia, so -10, -12, even with the risk of retinal detachment. Cataract in several leukodystrophies, in some it's even in the name. Glaucoma in Aicardi-Gouttière syndrome, for example. Retinitis pigmentosa in Francia syndrome. So many different ways of eye involvement, and you can find this information also in the recent review article on leukodystrophies. A nice table with all the possible extraneurological symptoms in patients with leukodystrophies, including eye involvement.
Okay. So there is another question. Are there adult onset leukodystrophies that can be treated with HSCT?
Oh yeah. Yeah, thank you. I think the honest answer is that we don't know for sure, although I think that patients with a pre-symptomatic or early symptomatic metachromatic leukodystrophy are eligible for bone marrow transplantation. And we have patients who were transplanted as young adults who are now have been completely stable for the last 20 years. Whereas their affected SIP has completely gone downhill or even already died. So I think that this is a good group of patients to transplant, the adult metachromatic leukodystrophy patients. For the adult form of cerebral X-linked adrenoleukodystrophy is still the results are not that good and still a question of debate. And then there is this, well, I wouldn't say new, but this autosomal dominant leukodystrophy with the neuroaxonal SP. And also when you are early with the diagnosis, that patients might or probably profit from hematopoietic cell transplantation, although the numbers of treated patients are still very small.
Sorry, I was muted. That's why you couldn't hear me. Okay, so there is one question. What about pre-symptomatic VLCFA screening in newborn males? Nicole, can you hear us? It seems that we have lost Nicole. We can wait a little bit longer, but it seems that there are problems with the connection. So I see, I think you may address her through email for those questions, or she said that we will have other webinars on leukodystrophies. They will follow in the next time, so stay tuned on our website, and then you will get also some information on gene therapy. Maybe we still don't know the exact topic, but you can ask those questions also there. So I have added now the link for the website where you can find these recorded webinars and the slides. Thank you very much, everybody, for joining. Unfortunately, we have lost now, Nicole. There is no sound anymore. Thank you, and welcome to the next webinar, which is in 1 week, and it's in the disease group dystonia.